Good day, everyone. I'm Dr. Sipache Basit, and I am your professor in today's course, Immunology and Serology. And for today, we will be discussing about the spirochete diseases or spirochete diseases. Okay, so in this particular presentation, we will be discussing the syphilis, Lyme disease, and relapsing fever. So we'll be covering the causative organism and transmission, clinical manifestation, and laboratory diagnosis. So let's talk about first syphilis. So syphilis is a sexually transmitted disease caused by the spirochete bacterium Treponema pallidum. So it can easily be destroyed by heat, cold, and drying. In fact, the blood-borne transmission is rare because if the blood, if for example the blood has been stored in the blood bank refrigerator or cold temperature for quite some time, the organisms apparently becomes inactivated. So how do we get syphilis? Usually by direct contact with open lesion is needed. That is the reason why wearing of condom may even minimize but not totally prevent the transmission of syphilis. So transmission to fetus during pregnancy is possible. So that is the reason why we also have the so-called congenital syphilis. So the primary stage of syphilis would be the development of the chancre. So or chancre. So this particular chancre is actually a painless ulcerative lesion. So this one is highly infectious. So a direct contact with this lesion would lead to the transmission of syphilis. And then of course, after the primary stage, we have the secondary stage wherein generalized lymphadenopathy could be apparent, malaise, fever, pharyngitis, and rashes. Rashes all over the skin would be apparent even in the palm and even the soles of the feet. Okay, and usually the latent stage is asymptomatic. Okay, now the tertiary stage is characterized by gamma. So it's a gummatous lesion, meaning to say there is a deformation okay, on the face. So that is one of the most common manifestation of gamma. And then cardiovascular involvement, and of course neurosyphilis, wherein pavus dorsalis and even paralysis may be possible. So treatment. Um, Effectively treated with antibiotics such as penicillin, particularly when detected during early stages. Now, as what I've told you, congenital syphilis is actually the transmission of the bacterium treponemes to the fetus. It occurs when pregnant woman has early stage or latent syphilis. So that's possible. So it causes death in 10% of cases. So live-born infants may be asymptomatic at birth, but apparently they could develop symptoms later on. So at first they'll have runny nose, and then eventually skin rash, generalized lymphadenopathy, hepatosplenomegaly, jaundice, anemia, bone abnormalities, and of course, we do not want this to happen, neurosyphilis. So in some have actually reported interstitial keratitis wherein they become blind. Okay, any deformity as a result of the congenital syphilis, that is actually termed as stigmata. Okay, so how do we detect syphilis? Since it's quite difficult to stain them using gram stain, direct detection using dark field microscopy or fluorescent antibody staining, which is more sensitive, would be most ideal. So we can demonstrate treponemes in active lesions. However, that is not really a common method in the laboratory, because the most common method, of course, would be serologic testing, either by the non-treponemal test or the so-called treponemal test. So non-treponemal test detects antibody against cardiolipin. So we call it reagin. Okay, so reagin. So what is a cardiolipin? Cardiolipin is a lipid released from the membranes of cells damaged as a result of the infection, which means that in non-treponemal tests, we do not detect syphilis antibodies against the organism itself, but we are detecting reagin. Reagin is developed whenever whenever the cells are being damaged. For example, there are lesions in the genital area, so there's a damaged cell. So whenever there's a damaged cell, so it will release a substance called cardiolipin. And of course, our immune system would be developing antibodies against that cardiolipin. And that antibody is reagin, and that is the one being detected in non-treponemal tests. Okay, so the classic non-treponemal test is known as the VDRL, Venereal Disease Research Laboratory. So this may not really be popular unless you are using the latex modification, but the classic VDRL would require inactivation of patient serum, which means that you have to heat the serum at 56 degrees for 30 minutes. Of course, a more popular test would be the RPR, or the Rapid Plasma Reagent Test. Perhaps its main disadvantage is that we cannot use this for CSF sample. Hence, it's quite difficult to use it to diagnose neurosyphilis. So, positive reaction in non-treponemal test is flocculation. So, contrary to many beliefs, flocculation is not an agglutination reaction, but instead we classify it as precipitation reaction. So it is a precipitation, a low-grade precipitation reaction. So during the screening test, we are using undiluted patient serum sample, and if in case that the patient becomes positive, then we can determine the titer using the twofold dilution. Okay, so let's talk about the VDRL. So in VDRL testing, the patient serum is mixed on a slide with cardiolipin, lecithin, cholesterol, antigen suspension. Okay, so we are using the cardiolipin, lecithin, cholesterol, antigen suspension. So it's an antigen suspension that has to be prepared, okay, on the day of the test itself, because the viability of the diluted antigen is just for 24 hours. Again, unless you are using the modification of the VDRL, which is the latex VDRL. So here, we rotate it for 4 minutes at 180 RPM, and we view it under the light microscope, and we look for the presence of flocculation. So we report it as reactive. If there are medium to large clamps, weakly reactive only if there are small clamps, or non-reactive, meaning no clamps or slight roughness. Okay, so in RPR test, the patient serum is mixed on card with charcoal particles coated with cardiolipin antigen. So we rotate it for 8 minutes at 100 RPM, and we observe for the presence of macroscopic flocculation. Okay, so it's actually rapid because you do not need to inactivate the serum for 56 degrees for 30 minutes. So you can right away use the patient serum, okay, using the charcoal. And the charcoal here is actually absorbed with choline chloride. And that is the reason why there is no need for us to heat inactivate the serum. So as you can see here, here's an example of flocculation, okay, of reactive patient. And this is an example of non-reactive patient. So usually if the patient is reactive, we further dilute it so that we'll be able to determine the titer. Okay. So what are the disadvantages of non-treponemal test? Non-treponemal test is not confirmatory. So that's the reason why we just report it as reactive or non-reactive. We never report it as positive. Okay, or we never report it as positive whenever we see flocculation, because this is just screening tests. So the one, of course, that is confirmatory is whenever we perform the so-called treponemal test. Okay, in treponemal test, we are detecting antibody to Treponema pallidum itself. So we're not anymore detecting reagin, which is an antibody to cardiolipin, but instead we are detecting antibody to Treponema pallidum. So again, the most preferred test here is the FTA-ABS, the fluorescent treponemal antibody absorption. Before, when I was still in college, we were taught that the reference test is the TPI, Treponema pallidum immobilization test. Um, well, that's quite difficult to do because you are required to have a live Treponema pallidum. And whenever this live Treponema pallidum is immobilized, that is considered as a positive result. Imagine you have to maintain, you have to get live Treponema pallidum from the chancre of the rabbit, testicular chancre of rabbit. Imagine you have to maintain a rabbit with syphilis in order for you to do the TPI or Treponema pallidum immobilization. So, fortunately, we're not doing that anymore. Okay? Unless for research purposes. It has to pass uh, animal ethics for that matter. Okay, and then we also have the Treponema pallidum particle agglutination. And then, of course, this has been discussed before in labeled immunoassays. So we can actually do the ELISA, the chemiluminescent immunoassay, and then the multiplex flow immunoassay. So let's talk about the one that is considered to be as the most ideal test when it comes to treponemal test for syphilis. This is the FTA-ABS. So it is an indirect immunofluorescence test for antibody to Treponema pallidum. So since it is indirect test, we are detecting for the presence of antibodies, okay, using patient serum as our specimen. So what will happen here is that patient serum is incubated with sorbent. So when we say sorbent, this is actually an extract of non-pathogenic treponemes so that we remove cross-reacting antibodies. So once we have incubated it, we call it already the absorbed patient serum. And it is further incubated within a microscopic slide. So the thing here is that you can actually acquire this microscopic slide from the manufacturer, and it has already fixed Treponema pallidum. So you have to do the washing procedure so that you remove any unconjugated particle, and then we add anti-human immunoglobulin conjugated with fluorescence. So this one is being added. What is this one? This anti-human antibody will bind at the FC portion of patient's antibody. So hence you have the complex. In the slide you have the Treponema pallidum, and then next to that is the patient's antibody if the patient is positive, and then of course the fluorescein, which will actually bind at the FC portion of the patient's antibody. So after a second incubation and wash, slides are examined under a fluorescent microscope. So it's like this one. So you have here the Treponema pallidum in the slide, and then you add patient serum with patient's antibody, and then you add anti-IgG, fluorescent labeled anti-IgG. If the person is positive with syphilis, what will happen is that the organism will glow in the dark, such as this one. Okay, so that is the FTA-ABS, fluorescent treponemal antibody absorption. That is an example of IFA, which is the indirect fluorescent assay. Okay, so this one is the Treponema pallidum particle agglutination. Well, this one wouldn't require you to have a fluorescent microscope, so this one is actually much cheaper, I guess, as compared to the FTA-ABS. So what will happen here is that patient serum and controls would be diluted and incubated with unsensitized gel particles or gel particles that has been sensitized with Treponema pallidum. So a positive result would be agglutination, covering smooth matte covering surface of the wall. As you can see here, this is an example of a positive reaction. And then test no agglutination if you've seen buttons. So this is considered to be as a negative reaction. So this one is being performed in a microtiter. And of course, we have the automated immunoassays, the ELISA, the CLIA, and then MFI. So I will be including supplemental videos in this particular module so that this would be further illustrated. Okay, so this would be the typical antibody patterns in syphilis. So during the time of infection, you do not develop antibodies yet. Hence, you cannot detect it in serological reaction. Okay, so however, during the primary stage, so you can actually see here that non-treponemal test would be positive alongside with the treponemal tests such as the TPPA, FTA-ABS, or even the enzyme immunoassay. So as you can see, the latent stage of syphilis is asymptomatic because here in primary you have chancre, here you have rashes, here asymptomatic in tertiary you have gamma. 10 years after. Okay, so as you can see, during the secondary stage, you can still detect antibodies. However, the titer of antibody decreases, particularly in asymptomatic stage. Okay, in asymptomatic stage. Okay, however, for untreated cases, the antibodies remain persistent. Okay, for both treated and untreated cases. Okay, antibodies, treponemal antibody test persists, can be detected for a much longer period of time as compared to the non-treponemal test. Explanation? Because in non-treponemal test, this is antibodies against reagin, and reagin reacts against cardiolipin, and cardiolipin will only appear if you have an active lesion, because cardiolipin again is a lipid that is being released whenever the cells are being destroyed due to active infection. And this explains the reason why the titer is not that high as compared to the stages wherein the patient is actively infected. Okay, so this is the algorithm now for syphilis. So the initial screening would be the non-treponemal test because it will be more expensive. It will go directly to the treponemal test. So if the result is non-reactive, it means that the patient is negative for syphilis, so no further testing is required. However, if the result is reactive, it means that it's possible that the patient may have syphilis. So you have to perform treponemal test. So if it's non-reactive, then it could be biological false positive result. Means the patient is simply negative for syphilis. But if the person still reactive, it means that the person is positive for syphilis or has been untreated for syphilis or recently treated cases for syphilis, because again, it's actually positive, okay, for a very long period of time, persist much longer. Okay, and we also have the so-called reverse testing algorithm for syphilis. What does it mean? It means that we screen first with an automated immunoassay for Treponema pallidum. So if it's positive, we do the quantitative RPR or other non-treponemal tests. If it's positive, means that the person has syphilis, it's either in the past or presently having syphilis. But if it's negative, we do the Treponema pallidum particle agglutination. If it's positive, then it means that the person may have syphilis in the past or in the present. Or if it's negative, it is unlikely that the person has syphilis. So in reverse algorithm, it is being confirmed with an RPR and also perform TTPA on samples with discrepant results. Okay, and there's also special diagnostic areas. So we also have the molecular testing for Treponema pallidum's DNA using PCR. It may be sensitive alternative to dark field microscopy in the future, but kind of more expensive, of course. And then patient monitoring is being performed, particularly to perform non-treponemal antibody titers. So what does it tell us? Because titer declines whenever there is a successful treatment, as you can see in the graph a while ago. Congenital syphilis is better perform non-treponemal test on mother and infant at birth and then IgM-specific treponemal assay to confirm it. Okay? For neurosyphilis, we cannot do RPR for in the CSF. So we perform using VDRL or ELISA on. Okay, so the one that is not really popular in the Philippines are the next or the succeeding treponemal diseases that I will be discussing. So we have here the Lyme disease caused by Spirochete Borrelia burgdorferi, and of course it is a vector transmitted infection. It is being transmitted by the bite of Ixodes tick. So the main reservoir would be the white-footed mouse. Okay, so here like clinical manifestations would include rash during stage 1, and then stage 2 early dissemination. So, and then stage 3 is the late dissemination with arthritis. So this is one kind of disease that may even cause juvenile arthritis. Okay, so Lyme disease. So for the laboratory diagnosis of Lyme disease, so we usually screen it with immunofluorescent assay or ELISA for antibodies to Borrelia burgdorferi. So antibodies may not appear until 3 to 6 weeks after you have bitten by the tick. Okay, so that's the screening test. To confirm, we have to utilize the Western blot assay. In the Western blot assay, positive for IgM means that there are 2 out of the 3 characteristic bands. Okay, but for IgG, there should be 5 out of the 10 characteristic bands. Okay, so another example of treponemal disease is relapsing fever. So this one is caused by Borrelia miyamotoi. It is transmitted again by Ixodes tick and may cause flu-like illness, skin rash, relapsing fever, which means that the temperature of the person becomes on and off, high, and then becomes normal, and then high again. So on and off fever. So it's a flu-like illness characterized also by skin rash, and laboratory testing would include ELISA, and PCR may be utilized in the future. So it's a research gap. Okay, so again, this has been Dr. Syphilis Basit, and that's the end of our discussion for Spirochete disease. So God bless everyone and stay safe.